Hello and welcome to another episode of Plastic Surgery Unfiltered. I'm your host, Dr. Armando Davila, and I'm joined by a very special co-host today. At our podcast, at the intersection of healthcare, business, and the beauty industry, we're going to be talking about going deep. Are you getting the right plane facelift? How are you today? I'm here with Dr. Isaac James. How are you doing?
Hey, I'm good.
I'm going to give you a little introduction here. So Dr. James is a plastic surgeon here in Pittsburgh, and if I'm not mistaken, you're an assistant professor, right, of plastic surgery at the University of Pittsburgh. And he's actually the director of aesthetic education in the department. He completed his training at UPMC, right, and then you did your aesthetic fellowship at Cleveland Clinic under James Inns, who is a kind of facial aesthetics expert.
Exactly, yeah.
And so today we're having a fun conversation about, advanced facial aesthetic procedures and kind of the confusion, I think, behind some of it, right? I think that we'll start with this question. When patients come in for asking for a facelift, do you think they really understand what that means? And what do you think there's a mismatch between what a patient thinks is happening versus what's happening surgically?
Yeah, I mean, I feel like there's a wide variety, really, of sort of where people are at when they start, when they come in. Some people have done a lot of reading. Some people have just looked at some stuff on Instagram. Mm-hmm. I think that's part of our challenge and job, really, is to figure out where people are started and try to get them up to speed educationally. But it definitely, there are pros and cons to, we'll probably talk about this later, to the whole Instagram thing. Yeah. On the one hand, it's really democratized access to knowing about plastic surgery. But on the other hand, sometimes it can sort of skew where people start educationally.
So I think that one of the sticking points that has become popular on social media, and you're right, we will get back to that, is this concept of the deep plane. And so, to you, if you would define the SMAS the way you think about it, and why is it important in facelifts? Why is this deep plane becoming important for people?
Yeah, I think first off, the reason the deep plane has become popular, I think there's good reason behind it, right? The SMAS is fundamentally the architectural layer of the face. It's sort of the scaffolding with which we move things on. And if you look anatomically, right, the glide plane of the face where your facial musculature moves, all of that is in the sub-SMAS plane. So it makes sense, right, to use that natural glide plane to move things around. Mm-hmm. So I think there's a lot sort of to it. And to be honest, at least in the common sort of current perception of what a deep plane is, I think we both do it a lot, right?
Mm-hmm. Yeah.
So, I think there's something to it, but to say anything is right for everyone is kind of, I think, a reach.
Yeah, I think that that's a great point. That was the little pun that we had talked about the right plane for each person. I do think that an analogy for me is, or I try to say this during the consultation, is that, people see the bed sheets, so to speak. They see their face, they see the wrinkles, they see the kind of sagginess to the sheet, and they think that, we'll just tug on the sheets and that will sort of solve the problem. But really, it's that the mattress has aged, right? Mm-hmm. And so the mattress has thinned out or flattened or has folds in it, and you can tighten the sheet, but it's going to sort of re-wrinkle over time, very quickly, and you need to really do something structurally about the mattress. Now, what you do structurally about the mattress, I think, can vary from person to person, totally. And so I do think that's part of the issue, right? Mm-hmm. Being in the SMAS or dealing with the SMAS, I think, is also not the same as being able to move the SMAS. Yeah. What do you think is, for you, what does it mean to sort of mobilize the SMAS versus sort of just tighten the SMAS or plicate the SMAS? Why is there that difference?
Yeah, I think what that fundamentally comes down to is what you're doing with the retaining ligaments, mm-hmm. right? Plication versus any kind of sub-SMAS release, you're taking two different strategies at a problem. On the sub-SMAS release, we're releasing the retaining ligaments, so we're releasing the zygomatic ligaments and the masseteric ligaments to really give us mobility so that we can move in the glide plane. Whereas in the plication, you're basically just taking the mobile part of the SMAS and plicating it up on itself. And, those things have advantages and disadvantages depending on what you're trying to achieve, right? If you're trying to stack SMAS in a very specific location, sometimes the plication does that better than what you can do with a deep plane or, high SMAS, whatever you want to call it, technique.
Absolutely.
And then the same thing goes with patients that have really wide faces, right? Like you might want to do either some SMAS trimming or SMASectomy so that you're not making them wider. And I think that those nuances are a lot of the things that get missed a lot of times when we just want to see like a branded technique online.
Yeah.
But I think most of us that are doing this at a high level are thinking about these things and sort of applying it that way on a case-by-case basis.
Yeah, I mean, like one of the things that has become branded and was probably one of my favorite brandings so far I've seen is this kind of omakase idea, which is like, right, and you like to travel to Japan, so you're very familiar with the concept of actual true omakase, but it's sort of like, chef's choice, so to speak. And so but it's sort of funny right away. It's reversed, right? Mm-hmm. Omakase has become like, this type of facelift. No, it basically means the surgeon is going to choose the right plane for you, the right set of procedures for you based off of like the goals that you have. And that surgery could be, 2 hours long. It could be, 9 hours long, I guess. But I do think that like it can give some freedom to the surgeon. Yeah. One thing that's always I've struggled with explaining is if you can placate the SMAS and people do that for a facelift, why don't threads work?
Yeah. I think I love that question because I think one of the big misconceptions, I guess, with maybe non-plastic surgeons, like thinking about like what we do, it's not so much about the repositioning that we're doing. It's about you're creating a tissue plane. Like your body has to hold the result in the long term. Our sutures are only going to be good for a little bit, and all of the sutures we put in, the whole point of them is just to hold things in place so your body tissue can heal and can create those scar planes, essentially, that are going to hold the result. So the problem with threads is, it lifts the stuff, but it doesn't create any kind of tissue planes, open areas of dissection to readhere. So it's just going to fail as soon as the suture fails. And sutures, they just don't last.
Yeah. So, I mean, I think that like one of the things that they like to put about is, these like will make collagen. Like, what do you say to that kind of?
Well, I think on one side of it, you've probably seen this when you've operated on patients that have had prior threads and had to like take them out, right? Mm-hmm. They always have those like tunnels where the threads were, which are collagen essentially. Mm-hmm. But to think that those are enough to hold the face up, the reality is it's not the case. Yeah,
I think that you're absolutely right? You see these collagen like little like lines, and it just doesn't have enough tension and power. And I think that this is a pure surface area issue. And that's why, especially mobilization techniques or sub-SMAS techniques, you just get a whole like brick of surface area that's going to hold that tissue as long as possible. And that's, I think, the confusion about longevity, right? That's a question that I find fascinating in facelift surgery because we don't ask that about our tummy tucks. We don't go, how long is this tummy tuck going to last? It's sort of fundamentally permanent. Yeah. But because the facelift is not so much about skin removal, it's more about repositioning, there is a duration correlate effect, I think, based off of the surface area that you get, the contact surface area you get. Yeah. So then if we were saying that about threads, then what about all these like mini procedures and cabling procedures? In a sense, why are those effective or why aren't they effective? Yeah. In your mind?
I mean, I think what you just said about surface area is really the key point, right? Like the mini procedures, they're going to open up more surface area than say a thread would, right? A thread's basically zero. A mini, depending on how you define it, right, could be anything from, a few square centimeters up to like, a fair amount. Yeah. And, so that part, I think if you are raising a high surface area, then you're going to get a result that's at least somewhat durable. And I think when we think about things, I think we both tend to think that some of the sub-SMAS work tends to hold a little bit better. And if you think about that, it has a wider or a larger surface area than even a plication does. Right. And, plications have a great surface area of tissue healing to hold things.
Again, depends.
But when you start talking about the minis, you're even less, right? So I think that may be a big part of the explanation.
I mean, my wife and I have been rug shopping recently, okay? And I saw another good analogy, which was, we lay down the rug and we put it under the dining table, but we're not happy with where it is, right? So what we're doing is, because we can't lift the dining table, is we're kind of just like pushing the wrinkle like over. And if anyone has had a rug and ever like adjusted the wrinkle, it's sort of like you're shifting the wrinkle around, and inevitably like 3 days later, the wrinkle starts to like reappear because we haven't sort of really repositioned the rug, right? And I think that that's another good analogy for me and for patients. I never talked to a patient about this, but I'm going to use it, I think, next time, which is like, again, SMAS work is like me taking the table off, like putting the rug where it goes, and then like putting the table back on. And I can use fancier techniques. I can go and take like big rug hooks and try to like yank on it harder. But at the end of the day, until you get that full surface area coverage, there's going to be some lost tension in the rug, so to speak. And so let's talk mini for a second, right? There's the I think that there was like some shade thrown about like mini facelift, mini results, or mini tummy tuck, mini results. And I think you're right. The problem is that there's no concept of like what mini means.
Yeah.
Like I've done minis. When you do a mini, again, there's not one right answer here. Like, what are some things that you consider mini about facelifts, or like that you would modify?
Yeah, I mean, I honestly, I don't really like the term because it's so ambiguous, right? Like, and I try to take my approach, which I think yours is similar, is I'm always trying to make the anatomic diagnosis, what's going on, and how can I address this directly and in the most like sort of way. So, that's my problem with a mini. Like, so a mini could mean a shorter incision, right? It could mean less dissection. Like, I may put that on my for my OR bookings, and mini facelift for the OR people, but like what that actually means anatomically, that's going to vary on a case-by-case basis. And usually I can figure that out when I examine a patient and talk to them and see what their goals are. And I can tell them exactly what we're going to do. And I say, we'll call this a mini, but like, this is what a mini means in this case.
In this context,
right? So it could be that we're not going into the neck, right? It could be that we're going to do application with like a little less undermining because they really have very little that they need done and they don't want the longer recovery of more dissection. It could mean that they don't really want much fat grafting because they don't need the volume, so we're going to save some time on that. So I think for me, the mini is more of a time issue, right? Like if there are fewer things I need to address, then we'll call it a mini. But again, it's going to be like, I'm going to be like, we're going to do this set of procedures for you because these are the things you want. Yeah,
and I do think that there's a correlate too, right? That this idea that, okay, a longer surgery is going to be longer recovery, and I think that that's sometimes true, but not in all cases, right?
Yeah.
Like some things may be inconsequential to recovery, and some things may lengthen it a lot. For example, the laser may not take very long, but if you completely laser their face, it takes you 30 minutes, but that will increase recovery like double,
Yeah.
So they're not one for one. The second part I think about minis, gosh, it is a nomenclature problem, right? Let me talk about like let's think of rhinoplasty, right? For us, right? Dorsal preservation is obviously like a whole topic and for another podcast. But you don't necessarily go and tell the patient. I mean, you might tell the patient. It's like, okay, well, we're going to do your rhinoplasty. We're going to like do a dorsal hump reduction. We're going to do cephalic trims. We're going to do, alar batten grafts. We're going to do, septoplasty. All the little components that you're going to do. But on the paper, it just says like rhinoplasty, right? And I think that many patients kind of just trust there. They're like, they don't know what an alar batten graft is. They're just like, this is the result I want.
Yep.
Can you get me that result? And then we talk to them about each step, but really we're just going to do what we need to do during the surgery.
Right.
For some reason, facelifts and neck lifts are not like that, right?
Yeah.
Social media, and that's why we come back to the omakase. Like that surgeon is sort of restoring it back to normal, which is just like omakase facelift is just a facelift. We decide what we do, and but patients struggle with that. Why do you think they struggle with that in this environment? Do you think it's a social media thing? Do you think it's a results thing?
I think, it's a tough problem, right? Like, facelifts are immensely complicated. I mean, as are rhinoplasties, right? But for some reason, because everyone wants to have some semblance of control when they undergo surgery, right? Like you're giving up control. So at some level, anything you can do to like maintain some control in the process, like I get it, right? So having an idea of like, I want this particular type of procedure, and feeling like you're directing that, I think I see where that comes from, right? But I think what we are more thinking is we want the patient to direct what they want from a results standpoint, not necessarily like what route are we going to take to get there, right? Like it's my job to get you to the destination that you want to get to, but maybe the route you're thinking is like, not the best one for you. We could get there, safer, faster, or whatever by going a different way. And I do think that like looking at surgeons before and afters is important, right? Because at the end of the day, that's going to tell you a lot about what they can deliver. But I would more focus on the destination, I guess, than like how you're getting there. I think it's a valuable sort of discussion to have about how you're going to get there. I like talk to my patients about, I think this is the strategy we're going to take with you, but like, hey, if we, encounter something unexpected, we may do something a little bit differently. I mean, I know we've both had the patients that you go in and they're like, yeah, I never had any work done on my face before. And then
that just happened to me.
Yeah. You see scar tissue planes, you see threads that are still there, you see, and you didn't know that going in, and then you have to adapt on the fly. And that's why you go to someone who specializes in these things, who knows how to handle those sorts of things.
Bingo. And I think that's the difference that sets apart like people who do a not one-size-fits-all surgery versus surgeons who only know how to do one technique. Again, you and I and other surgeons in the city know how to encounter and what to do in the deep spaces, but we also know how to handle the superficial spaces, right, and get a good result. There was the paper that was talked about at Baker Gordon. We went together about how, or I think they said it, which they did the split face study where they did a deep plane procedure and then a SMAS plication or whatever, and there was no like visible difference. Yeah. I think when did they carry it out to a year? I think. Yeah. It was a short term, so it wasn't full, but that basically you couldn't tell the difference. And I just had that happen. I had a patient who had certain amount of scarring on one side, and I ended up having to abort sort of the mass elevation on one side, and they were still very symmetric. I modified the technique to get as much symmetry as possible. But yeah, and I think that this is. I want one more question before we get into social media, but we have this problem where, in before and afters, right? It's like if I show someone before and after and then they go, well, how big are those implants? And I go, well, those are 450s, but the 450 is not right for you, right? They're really saying, I like that result, right? What do I need to do to get there? But social media has started to structure us in a way that says, well, if that person got a deep plane and they look good, then I must need one to also look good. And that's not necessarily true, is it?
No, it's not. Yeah. I mean, again, that goes back to the surgeon, right? Like, I think, you see a lot of great results on someone's Instagram for their deep plane techniques, and you're like, what they're really saying is I want that result. But because they're associating it with the technique, they're saying I want that technique. But you and I both know that the same technique in a different surgeon hands is completely different.
Correct.
And I think it's a lot of it, we talked about this before, a lot of it is all of the little subtle sort of small tweaks that everyone makes for their techniques. Like every technique has pros and cons. And I think a lot of the learning curve, especially in facelift surgery, is figuring out how to compensate for the cons of the technique that you like. And so, the people that get really great results with, say, SMAS plication, they're doing a certain set of things that are compensating for the limitations of that procedure. Same thing goes with a deep plane, right? So,
like what? Tell the audience, I think, some of the things that compensate.
So for instance, with SMAS plication, right? Like you can pick your vectors a little bit better. That's one of the advantages, because you can literally plicate wherever you want to plicate. So sort of the way you're structuring things underneath, I think you can compensate in some ways. And when it comes to let's say like doing the deep plane work, right? If you're doing a true composite deep plane, you're a little more limited in your vectoring, right? Like you can't separate the vectors of the SMAS and the skin as much. And so you're going to change sort of the way that you approach that slightly to sort of address with those weaknesses. Fat grafting is another great example, right? Yeah. Like your fat grafting is going to be completely dependent on what you're doing underneath. And
Correct.
So like I think everyone, over the course of their career and their experience with these things, you start to notice the things that like, the way you like to do it, it may have some limitations. And then you start to develop techniques and ways to deal with that. But those nuances, they don't come across when you're talking about the overall deep plane facelift.
Overall picture, yeah.
Yeah, and I think like the neck is a great example of that we both, I think, feel pretty strongly about.
Yeah, let's talk about that.
Yeah,
Go ahead.
So like we're always talking about, what are we doing in the face? But I think that the neck is like, in my opinion, as important, if not more important than what you do in the face. When it comes to deep plane, I would say deep plane in the neck is pretty much, in my opinion, the only way to go. But I think that, obviously people get great results doing other things as well.
Yeah, I mean, like the, when you put on your reservations for the operating room, do you put face and neck lift, or do you just put facelift and then do the neck?
I generally, I used to say face and neck lift, but now I think of it as one thing. That's what I was going back to with mini facelift, right? I've kind of moved towards, if I'm not doing the neck, that's more of a mini face.
Okay.
But I'm generally doing the neck because unless a patient really either maybe they had a previous neck lift that's held up well and they don't want it, or they just generally are happy with their neck. But I mean, that's a fairly small percentage of people, I think, in the general facelift population that don't benefit from a neck.
Yeah.
So I'm generally doing the neck.
Okay.
Yeah.
Yeah. I mean, like, I've struggled with this. We've changed this like 6 times in our office. And so, it was originally facelift and then like face and neck, then we went back. And then we started putting like what layer of SMAS. I started thinking about it like CPTs, right? Because the CPT codes do have a differentiation between like SMAS work and non-SMAS work, and then open platysmoplasty and not. So I was just like, you know what, I'll just match it via CPT. So we are now also, we've moved back to doing face and neck lift. And that way, again, it's just an ability to understand what we're doing for the day, so that the OR staff knows what we're doing for the day. But I'm not sure it totally matters. One thing that is a different phenomenon though here than I encountered in California or in Las Vegas was most patients come in asking for neck lifts at our office. Is that something you've encountered, or not really? Is that just a Pittsburgh thing?
I think it might be a Pittsburgh thing.
Okay. It's
definitely like, especially if you look at like the male population, right? Most men are not coming in saying they want a facelift. They're like, I don't like my neck. Can you fix my neck?
Yeah.
And so, I think that definitely the neck lift interest is catching on, right? Like I think people are starting to see it because, again, in my opinion, at least in the market we operate in, right, like most of what people really want is they want that great result in the neck with a little bit of, repositioning in the face as well.
Correct. And I want to stop you there because that, I think, is a super important point. I think that people come in and they say a neck lift, but the jowl is particularly problematic, and it is a transition of the platysma into the face. And again, if you're going to do deep neck work and are not going to necessarily be releasing some of those retaining ligaments or plicating or doing something to reposition at the face level, then you're going to have a lackluster neck result. And so I often need an incision like in front of the ear, to get that position. Is that something you've encountered too?
Yeah. So going back to like the anatomic problem, right? Like what happens with age is that the SMAS is essentially, it's falling, right? And it's falling partially into the neck. So some of that laxity you have from the neck is from your face. And so if you don't put it back, you're never going to be able to like fully get that submental result that you want. I think that's a reason for a lot of, one of the challenges, right, with facelifts long term is that people often will have some residual laxity in the submental region. And I think sometimes that's because the SMAS wasn't adequately lifted back up onto the face first before the neck is repositioned and fixed. So they're integrally related. And I mean, it's just like the brow and the face, right? Like it's all one unit, and you have to sort of address it as such, or you're going to be limited at each particular point. I mean, that's not to say you can't do an isolated neck lift. Yeah. You just have to understand what the trade-offs are. Yeah,
I think that's a huge, a very difficult thing for people to understand and explain, right? Like these are all. The SMAS is contiguous. It's one layer that just sort of connects completely through from the brow, the forehead, all the way down into the neck and all the way to the clavicle. And so, you can take little pieces and you can kind of reposition them, but it's going to have trade-offs in the longevity. It's going to have trade-offs in the result, and it has to be customized per person, right?
Yep.
And neither you nor I have a crystal ball. So sometimes it's like, well, how long is this technique going to last me versus this other technique? And again, it's not about the tech. It is about the technique, but it's not, right? It's about the right plane for you, not the plane.
Right.
And so that is something that I still struggle with, and trying to define facelift versus neck lift and in the cross integration. And if you only approach it from a very, I call here a limited neck lift, which is no facial incision, then you're only going to have a lateral pull, and this region is going to suffer. You're not going to have a good submental result, even if there is a submental incision, which is a little bit confusing.
Yep.
You know. Okay, so let's go then to the, I think this is where we can talk about expectations and social media kind of distortion. I think that what social media kind of helps us do or refocuses the conversation to is short-term results, right? Mm-hmm. And so, at 3 months, it doesn't matter if I did a mini, it doesn't matter if I did a little guy there, did a mini, or I did like a plication. It doesn't mean if I did a lift, like a SMAS repositioning. At the end of the day, we're going to look pretty good at 3 months.
Yeah.
So I don't know. How much do you think social media has kind of distorted good result expectations and this problem related to technique choice?
Yeah. I mean, everyone wants sort of the immediate, right? Like you want to see, everyone wants instant results, that kind of thing. I think that it's particularly difficult, like you mentioned with facelifts, because what we see at 3 months isn't the final result, right? That's just the beginning. Anything looks good at 3 months. I mean, we both.
At least in facial work can look very good in 3 months.
Yeah, it can look good in 3 months. Yeah, like for instance, even threads often will still look good at 3 months. It's really, I think, at a year when you start to see like the differences between things, because that's given the skin enough time to sort of relax a little bit, right? So you have that anything that's elastic, if you stretch it, is going to relax slightly. And so there is going to be, regardless of what technique you use, some partial recurrence from where you were at 3 months to 1 year. Mm-hmm. And so I try to talk to patients about that and say, hey, we may get if you say you're at 100%, a month after surgery, you might be at 90, 80% 1 year after surgery. Most people are okay with that. But I feel like if you don't warn people about that, then they're like, oh, what happened? It's like recurring, right? Yeah. That's just the natural history of how this works.
Yeah, quote unquote, it did not last.
Exactly.
Right? Yeah.
But in different techniques, you may be at 90% of the year, you may be at 70% of the year, you may be at 60% of the year. Some of that's technique, some of it's skin quality, right? Like, I know in Pittsburgh, we both see a lot of these patients who've successfully lost a lot of weight, especially with the GLP-1s now. And one of the challenges, I think, in that population is that the skin elasticity is often not great, right? Because it's been pre-stretched.
And we don't know. I mean, do you think we know why? I don't know why that is. We haven't figured out why this skin elasticity problem is such an ordeal. I do think that's another important component. We talk about I gave the analogy of the sheets being stretched over the mattress. I do think the reverse is true as well. If you replace the mattress, or you get the mattress all nice and smooth, and then you put the same wrinkly sheets on there, mm-hmm. and you haven't ironed the sheets, mm-hmm. you're still going to have wrinkly sheets.
Yep.
So the bed will look better for sure because the mattress is better, but you got to do something to both the sheets, right?
Yeah.
So I think you're a laser fan as well, right?
Yes.
For resurfacing.
I mean, a laser, anything you can do to help with overall skin quality, right? That's also why I'm such a huge fan of fat grafting, because mm-hmm. it also helps with skin quality. You have to do both. You can't just treat one or the other. But I don't know. I mean, it is a good question. Hopefully, how do we rejuvenate elastin in the skin, essentially? I mean, I'm excited that that's something that's probably going to be coming down the pipeline in the future.
Right.
But as of now, I think it's partially just a tissue expansion effect, right? Like if you've pre-stretched things out, those fibers, it's like the elastic waistband in the shorts, right, that have been stretched for a long time. It's not going to totally come back to where it was.
Yeah, I guess I didn't think about that. I mean, in standard facial aging, right, what we do see is a lot more UV damage, skin damage, maybe some collagenous degradation from UV exposure. So maybe we've lost elasticity that way. okay, I guess you can restore it via some of these like laser techniques. It's sort of curious because that's not how we see it in the weight loss population, right? We lose elasticity, but you don't always see it at the surface level. Right? It's not immediately obvious, right? If someone comes in, they tell me they have a 30-year history of tanning with Coca-Cola, and then they have all these like fine lines and wrinkles. I can see it visually that I have to resurface this person, that I have to iron the sheets and then also do the deep procedure, or not deep procedure, just do I meant like a facelift procedure.
Yeah.
But in the weight loss population, it's not always obvious that they've lost that elasticity to the skin, and it does sort of relax after, deeper work.
Yeah.
I kind of wonder, that's a good point. Like, how do we set expectations? For breast augmentation, we use Vectra, and we can say, someone comes in asking for the Kylie Jenner special, I can be like, well, this is what the 450 half under the muscle looks like on you. And then they'll be like, no, I don't like that. Right. But, if someone comes and says, who's the other Jenner? Mama Jenner is, Christian. Is that it? Christian Jenner? Kris Jenner. Okay. Thank you. Carly helping out over there. Kris Jenner comes in and she looks all natural, and everyone's like, well, she had this type of facelift. I can't like simulate how that looks on that person.
Yeah.
I don't know. What do we do about that? What do you think patients should ask for? What should we do as surgeons?
I mean, I think that kind of technology has to be right around the corner, right? Like,
maybe.
But I haven't seen it yet if it exists.
Yeah.
It's hard. I mean, I think all we can use is our experience, right? So, for instance, the massive weight loss population, if you talk to them, I'm going to tell them that, I know that historically, like no matter what I do, you're going to have some fair amount of recurrence a year. You're still going to look way better than you would have if we hadn't done anything. But that you're going to have some relaxation. And I often will tell those patients, like, you might want a little touch-up tweak at a year.
Okay.
And, if you approach that up front, kind of explain it, most of the time that kind of stuff, it can be either a smaller procedure, sometimes you can just do it under local, but just knowing that they may need a little tiny bit of retightening down the road, I think it helps a lot going into it. Like, they're still going to get amazing results. It's just a matter of like trying to predict where they're going to land. And I think the more we can do with that up front, like to sort of show people what to expect, the better off it is. But yeah.
You reminded me of something, and now I forgot, but showing people stuff up front, I'll come back to it. Like let's talk like geography and price, right? This came up with me in a patient recently where, again, I told you I started writing like SMAS plication or something. And then like some people came in and they came in, I can't remember if it was a husband and wife couple or like friends came in for consultation and like separately. And then they both came back eventually and they were like, well, why does this one say plication and this one says deep plane? And then there's like a slight price difference or whatever. And so, it's, SMAS, deeper SMAS techniques, SMAS ablation techniques take longer because they have a certain nuance, and we'll talk about why. But like, then therefore they could potentially be more expensive, but it's not always like 1-to-1. But you may go to like a prestige market like in LA or San Francisco or New York, and you may get into facelifts that are in like the 6 digits for that type of procedure, right? And so then I think patients from Pittsburgh go to a New York market and they pay more than they would here, and then they presume that they're getting that more advanced procedure, but it's not always true. What are things that patients can ask their surgeon to like figure it out? Yeah.
I mean, I go back to like before and afters, right? Like, but I think one thing that maybe a lot of folks may not realize about the before and afters is that you want to see a before of a patient that looks sort of like you, right? Like if you have a ton of extra skin, a really heavy lax neck, like that's fundamentally different than someone who has just a little bit of extra skin. Or if you lost successfully 50 or 100 pounds and you have all that extra, versus someone who's been, thin their entire life and just has like some normal like skin laxity. If you have a lot of sun damage versus different, all of these different types of aging are going to sort of impact the way that the results work on you.
Okay.
So you could go look and see before and afters from a surgeon who has a very, I say that the New York facelift population is not the Pittsburgh facelift population.
Sure,
right?
Yeah, it's very different.
So I think that having some understanding of like what, your anatomy and face structure can sort of look like before and afters is helpful. I don't know if I completely answered your question with that.
No, I mean, it's just very hard. I want to get into like I wrote some questions that I think I wrote, normally I do this rather spontaneously, but I wrote down some questions that like I thought that patients could ask, and you can tell me if you agree or disagree with them. But, it's the idea that price does correlate some with technique, but not entirely.
Right.
And how I really feel for patients. This facelifts and necklace is a very confusing thing, right? It's like, again, I go back to rhinoplasty. If you go to a certain rhinoplasty surgeon, you've seen tons of before and afters. I think that patients relatively understand that, like, this nose is not their nose, and that they just see that the surgeon is capable of a breadth of different types of noses, and they're able to produce a certain result. And they go, okay, well, I have confidence in that surgeon because they do all those things. And I like most of their end results, right? I think that facelifts aren't like that, right? Number one, like when I was, again, I have friends in New York. You have friends in New York, right? People wear their facelift with pride. So the before and after books are plentiful. And people post their facelift on social media as like a, oh, this was my, 45th birthday present.
Yeah.
Here, no one wants to. We're still in Pittsburgh, where no one wants to admit that they had a facelift, and that's fine. We'll kind of get there. I say it like people like say, oh, I'll wear my wrinkles with pride, or that my age spots are whatever. It's like no one says that about their heart. No one goes around being like, man, my coronaries are clogged and I'm proud, let me just leave them that way.
Yeah.
No, people go and they take care of their heart, and they take the medications to take care of their heart. And it's like, why aren't we taking care of our largest organ, our skin?
Yeah.
And those things matter. And so, but we'll get there, right?
Yeah.
I just think that we still, because we don't have that tool sometimes, we still continue to have a lot of misconception, I think, here in the Pittsburgh region around what these procedures mean.
Yeah, totally. I mean, I think it's a great point, right? Like, I think most people in the city recognize the quality of healthcare we actually have in Pittsburgh. It's incredible, right? But then we have the same quality with aesthetic surgery, but I don't think people necessarily realize that. And it is partially a branding thing, right, with the prestige markets, but we're doing the same procedures that are being done in New York, that are being done in Los Angeles. It's just that, it's less, people are less, they don't want people to know, right? So it's kind of exactly what you said.
Yeah. So they'll there's a New York surgeon who every patient lets them post on Instagram, and then you go and they post their 3-month results of their whatever New York branded, quickie lift or whatever, and they look great. And then you travel to New York for a quickie lift, and it costs you $50,000 anyway. And the patient doesn't realize that what they had was, I don't know, a cabling procedure or a thread-based procedure or whatever. And they look good at first, right? But over the year and 2 years, it kind of like fades. And for a fraction, not a huge fraction, but a less in Pittsburgh, they could be getting, a very complex, nuanced fat grafting, brow lift, customized treatment, and they just have no idea. And I don't really know how to even ask them. I don't even know what to tell them the questions they should ask to figure out, what is the right thing to do. Like I wrote, should the surgeon be asking Should they be asking the surgeon, what layer are you operating on? Is that important? Should they ask that at all?
I think just from the nature of trying to understand what the surgeon likes to do, it's a helpful question maybe to say, for the majority of your primary uncomplicated facelift patients, what's your preferred technique? And just like let them talk about it and then ask them why, right? Okay. Like,
say that one more time. Let's slow it down for the audience. I love that question.
So say, what is your preferred technique? Like if you have an uncomplicated or a primary facelift patient that comes in and you can do whatever you like to do, what would be your preferred technique?
That is a great question.
How did you get there, right? Like, why is that your favorite technique?
Yeah, that is a great question. Okay, everyone take note of that. That's the first question you should ask your facial aesthetic surgeon, because that's a very open-ended question that lets the surgeon kind of like explain what they do and why. And if they do 2 consultations or 3 consultations, they can get a feel for the surgeon and why they do something, rather than focusing on a specific technique.
Yeah, you want to know, like, how are they thinking about the problem, right? Like, and you'll find, I think, different patients are going to find different approaches that really resonate with the way that they think about things, which I think is good as well. You obviously, like, you want to be on the same page as your surgeon, right? And that kind of can help you get there as well. And sort of think about, like, it goes back to what I was saying earlier about all the nuances, right? Like a surgeon may say, I like this technique because of XYZ. And then you can ask follow-up questions like, okay, well, like, what are the weaknesses of the technique that you use and how do you compensate for those? And that's another question that gives you more information, right? And it can give you a better idea, a more big picture understanding of what's actually going on. I mean, at the end of the day, yes, facelifts are extremely complicated, largely because of marketing, not really because of like the mechanics of what's happening. Yeah. I think anyone can understand what we do, right? It's just we have to like sort of make it transparent and accessible.
Yeah, I mean, like you're making me think of how I explain some other things. Like again, in breast augmentation, my preferred technique is subfascial. Okay, I do not do just subfascial augmentation because, well, for a bunch of reasons, right? But there's a bunch of nuance that goes into deciding whether or not a person's a candidate for subfascial, and whether they need something else. And I guess that's a nice way for anyone, I think every surgeon, to position, this is my preferred way of doing it, and this is why. And then in you, I'm not going to do that because of XYZ reasons. One thing I've been thinking about a lot is time, right? Which is, if your surgeon says that they're doing some deep procedure, and then they're like, your facelift's going to be 2 hours, then those things don't line up. Is that a question that patients should be asking? Like, patients are often surprised at the length of time that probably your and I's procedures take.
Yeah, I mean, I think that's such a great question, right? Like, the amount of time it takes, even for a given technique in a given surgeon's hands, can be highly variable. And there's many reasons for that. I think that, like personally, right, I don't ever schedule more than one facelift in a day.
Yeah, it's always one.
I tell patients, like, you are my only priority this day. And hey, if we finish early in the OR, great. But I don't want that time pressure of knowing that I've got somebody else right behind you, and that I feel like I have to rush through this step, or that like I can't stop and like redo that stitch that's not quite perfect. Or when I look at things and I'm like, look at the vector of how I'm positioning the SMAS, if I'm like, oh yeah, I liked the second side better than the first side, like let's go back and tweak it.
Yeah.
Right? Like, I'm not going to leave until I'm happy.
Right.
And so I think having the freedom to like make your time a little bit longer if you need to get that result, it is totally worth it. And when I explain it to patients that way, I haven't had a single person who's been like, oh yeah, I want you to rush. Like, I want you to like get it done in like less time.
Yeah. It doesn't change the fact though that they are surprised, right? Because, again, you and I have this sort of philosophy of really, again, treating everything based off the anatomy seat, making the correct diagnosis, and then doing the things that are necessary to correct those anatomical procedures. But they are surprised, I think, sometimes when they've gone to a surgeon who is like, oh yeah, I do 3 facelifts a day, right? And I go, what shortcuts are you taking to succeed in doing that? And, really early on in my career, I remember that I felt time pressure by the colleague I was working with because, he did a faster facelift. And, in my hands, those results were not adequate, right?
Mm-hmm.
I was I was constantly taking people back for tweaks and little things and things that sometimes they were fine, but I didn't like.
Mm-hmm.
And so, nowadays I really do just say, like, this is the procedure for the day, and we're going to kind of focus on this. So yeah, I do think that still asking the surgeon time is less about how long the surgery is going to take and more of a key indicator of what they're doing, right?
Yeah.
If you're looking, if they've listed like 10 things they're going to do and then they're like, this is going to take 2 hours, there's something off.
Something amiss, yeah.
Yeah.
I mean, that being said, though, like, especially if you look at like early career versus later career surgeons, right? Like, we're all going to speed up as time goes along. There's good and bad in that,
Yeah.
right? Like, I think most folks tend to go towards a more like sort of prescriptive or well-defined like approach. Like, it tends to be more similar from one procedure to the next as they advance in their career. I think early on, we have a tendency, I'm including myself in this since I'm still, I consider myself somewhat early career, right?
I guess, yeah.
Even though we've both been doing this forever.
Yeah.
Is that, I still am going to like really try to do that omakase kind of thing. Like, I want to figure out what's going to be best for this patient, and I'll, change the nuances to sort of meet their needs.
Yeah. I mean, I think
so that does add time, right? Like, cause you have to go, you've got to,
Oh, I see what you're saying. Okay.
Yeah, because if you go in and you're like, every patient gets step A, B, C, D in this order exactly this way, it's faster. If you have a team that knows that you're going to do that exact order, that exact way every single time, it's faster. And I think there are merits to that, and in certain situations that's better. But at the same time, I think there is something missed if you start to approach everyone the same way and not try to really be more custom to each person's anatomy.
Yeah, it happens subtly. I do think that there's a selection bias, right? Surgeons that really do things only one way, and then patients see their photos and they end up liking those things. Then they end up like, it doesn't matter, right? The patients that come through the door are the ones who are also appropriate for that technique. And I think that's true of breast augmentation, true of rhinoplasty, true of facelifting. But especially in more complex markets like ours, that's not really the case. And I think customizing is actually, probably ideal in this particular market.
Yeah, I would agree.
I mean, like, Tim Martin, I mean, we saw him do live surgery on Baker Gordon. I mean, how long? I think he still took like 7-8 hours, right?
Yeah.
So,
I mean, I was going to comment on that earlier, right? Like, yes, there is this tendency of, because if you talk to a lot of surgeons who are great surgeons who do really fast facelifts, they're like, this is the experience, right? This is because I've done, 5,000 whatever of these that it's fast. And there probably is some merit to that. But then you look at the people that we really think are like, that I still admire, right? That I look at their results and I'm like, I like those results. Those are the kind of results I would be proud to be
share. Yeah.
And so those, and I'll be honest, most of those surgeons, they still take all day.
They take all day.
Yeah.
And so, I think that I've had a renaissance sort of like going back to this, again, it was very early. It was especially in board collection, just like this idea of, I very much felt like I was taking shortcuts. And again, the patients had good results, but it didn't feel to me like I was doing the best thing I could do for that patient at the time. So yeah, I think that's another part of it. The last question I have for you is a controversial one. Let's see if we can get into a discussion here.
Excellent.
Is when is the correct time for your first facelift?
So patients actually ask me this a lot, and
Okay.
I get the question on both ends, right? Like, is it too early or is it too late?
Okay.
And
is there such thing for you, first of all?
Too late? Too early. So I'll start with too early. If it's too early, would be if there's not something I can see, right? Like, one of my number one rules is I have to be able to see something that I think I can improve.
Okay.
And if the patient is complaining about something that I don't I mean, it's very rare that they're complaining about something that I don't see. Usually if they're saying something, I see it too. But if there's something that I see that I don't think, that I think the risk reward isn't there, right? Like if our chances of making it better are not like significant, and I think it's always possible to make things worse, then I would say you're probably too old now, or too young. So where would that fall? I'd say for most people, you're not going to be, well, again, it's controversial. In LA, people are doing them in their 30s for certain things, and there are like subtle early signs of aging that are getting improved with those procedures. So I wouldn't totally cut out like people in their 30s, but I think in general, most people are not going to be ready for a facelift before like 40.
Okay.
And that's still early, right? And it depends on your skin quality, how thin your skin is, how much laxity like people age at very different rates, especially when you start getting in the like 40 to 50 range.
And the weight loss people are now throwing this for the loop. So
correct,
you could you could have lost 100 pounds and be in your 30s and need a facelift.
Right.
So
yeah, and then on the older end, I've done facelifts. I haven't done anyone over 90 yet, but I've done several in people in their 80s who are otherwise healthy, who have no other major medical problems, and we get the medical clearance and make sure it's safe for them, and it's just fine.
Yeah.
So I think that's on the too old end. I think that the expectations of what you're going to achieve does very much depend on what your age is and sort of it's less about chronologic age and more like biologic age of your skin and your soft tissues. Exactly. And so if you're older when you're approaching it, your ultimate result is you're not going to look, if you come in when you're 80, you're not going to look like you're 30 when you're done. It's just not going to happen because of all of those things. My mentor in fellowship used to always say that the patients that get the best results with facelifts are the ones that need it the least. So it's those younger, earlier facelifts are the ones that, you can usually count on they're going to have like a really good result. Yeah. But it's more about like, again, the question becomes, it's the delta, right?
The delta, okay.
Because so the older patients, you may make a bigger before and after. The before and after may be more dramatic. But if you're looking at it from like a purely like how young do they look, or like if you're looking at like, quote unquote, how good does it look afterwards, then oftentimes the younger patients are going to have the better result.
Yeah, I think with age on the older spectrum for me, right, it's sort of like age stacking about the biologic age, right? If someone comes in and they've waited and they specifically are like, I waited because I wanted like to, I don't know, maximize this or something. Yeah. It's like they didn't just wait on the soft tissue descent. They didn't just wait on the SMAS layer. They probably waited on their skin too. Mm-hmm. And so there's a lot of things that have to be corrected in a very short period of time. And then they're like, okay, well, I want this one procedure to tackle everything. And it's very unlikely.
Yeah, no, I mean, that's a good point, right? Like, and I think the analogy is very much to like fitness, exercise, like general well-being and health. If you start it earlier, it's like investing for retirement, right? The earlier you start it, the better you're going to end up long term.
It'll compound.
It compounds, right? But it's also not a one and done thing, right? Like there's maintenance that's involved, and that includes the skincare, protecting yourself from the sun, sleeping enough. All of your other sort of general health things do actually play into this. And then the other thing with like when's the right time for the first facelift or whatever. Ultimately, it's when your jowls start to bother you is the simplest answer, I think, for most patients. But you can have multiple facelifts over the course of your life. So it's like, when does it bother you enough that it's worth undergoing surgery for? But also don't put it off, because you're missing out on all of that time that you could be enjoying the results of it. Like if you are ready for one at 50 and you wait till you're 65, you waited 15 years of like, potential results there.
Yeah,
you're not getting back.
Yeah. We have to wrap up, but like I have the controversy here. I actually do think that we have a limited number of facelifts that we can do. I mean, I like to prescribe to the rule of two. I think that we get 2 good shots at any particular anything. Two shots at the nose, 2 shots at the face, 2 shots at your tummy. Like, I think after that, the surgery becomes very complex and you have a diminishing returns effect. And so, I do have sort of a harder deadline, and I'm struggling with the massive weight loss population because they're coming in really early, and I'm concerned about what happens once they hit their 60s, 70s. I think that age in the 50s, like early 50s, is like really ideal. That carries people into their 60s, 65, and then you can do another one that carries them to their 70s and 80s. But if you're starting at 30, gosh, you're going to have to be really modifying that third technique quite a bit to like to make it look natural.
Yeah, I mean, I definitely agree that each additional facelift you're doing adds complexity and difficulty. There's no surgery in plastic surgery that's easier the second time around. It's always harder.
It's always harder, yeah.
I mean, I think that most people can get about three facelifts. Definitely the third one is harder than the second one, no question about that.
Yeah.
And, I wish we had more time to get into this kind of stuff about like people that have had all of the non-invasives and all of the things that we're seeing now actually make the facelift more complex.
Correct.
Like you could get into someone who's had a lot of energy treatments in their face and neck, and it's like doing a revision, or even harder than doing a revision, even though they're a primary. And so I think it's still to be seen how that would affect their second, third round, because
it is.
Yeah.
I mean, I just think that's why, to wrap up, I think you're not just choosing a procedure, right? You're choosing, a mechanism. You're choosing kind of the results. You're choosing these complexity things. And I don't think this episode made it any easier for anybody, but, but I do think, if there's one takeaway, for me, it's that there's a lot of great work being done in Pittsburgh. Like, don't discount this city just because, there are prestige markets. And I don't know, what's your takeaway from the episode?
Yeah, no, I would say that, if you want to get that consultation with the famous guy in New York or in LA or wherever, sure, do it. But, get a consultation here too. You might be surprised.
Okay, well, everyone, thank you so much for joining us. We've run a little long, but hopefully this was helpful for people. And if you want to know what is really appropriate for you, just come have a consultation with many of the excellent facial plastic surgeons in Pittsburgh. Again, this is Dr. Isaac James. He's at the university, and he's a fantastic surgeon and friend. So I thank him for being on the episode.
Thank you very much. It was a lot of fun.